Great. Thank you so much for coming. So what I will do is set the stage about women's heart health. And as context, we released a paper in partnership with the American Heart Association in June. And so I'll bust some myths as we go through it, and then we'll have an intimate conversation on what do you do about it. One thing before I start, I think it's important to understand, when I use the term women today, I will focus on cisgender women. Unfortunately, we do not have enough data to actually report on trans women, non-binary women, but we, of course, have the aspiration to do so going forward. So to anchor you on this report, we released a big report on all of women's health in January in partnership with the World Economic Forum. And the results that we found are pretty profound. The first is that most people know that women live longer than men. But what people don't know, and what we found, is that women spend 25% more of their lives in poor health. The next is, well, that's probably when they're old ladies and with wheelchairs, right? No. 60% of that time is actually in their prime working years. And what we found is you could mitigate this gap, close this gap, you could generate $1 trillion of GDP globally. And over a third of that is here in the US. The other thing we saw, which is this 50%, we found, unlike the way medicine does, is that women are not small men. If you ever think about it, most of you probably think about, why can we only drink one glass of wine versus men? What were you always told? You're smaller, which doesn't actually make sense if you look around. It doesn't actually make sense. It's actually not that. It's how you process alcohol. That is relevant for the entire way that all pharmacological agents are processed. Many of them are different. And if you actually look at all the disease burden on women across all conditions, ones that impact women uniquely, which would be the purview of the OB-GYN, things that impact women differently, like the presentation of the heart attack and cardiovascular disease, or things that impact women disproportionately, like autoimmune diseases, migraines, that's over 50%. So actually, the default should be male and female biology, not human biology. So as we reviewed and looked at this information, the key finding is that the majority of this gap, what we call disability-adjusted life years, is actually heart health. And this is what prompted us to reach out to the American Heart Association and say, we need to have a conversation. How can we elevate the impact of women's heart health in the US? And so we partnered with them, released this report, and it was amazing collaboration. The American Heart Association let us interview all of their leading experts to really understand the cutting edge and put together a perspective that is not the super clinical research academic, but really get into the details of what the opportunities are and the gaps. So I'm going to share some of those findings with you. So the first piece, I'm going to bust some myths. So the first one, which many of you probably have heard, which I'm sure, Barbara, you experienced, is that cardiovascular disease is a man's disease. I also have a personal story. My grandmother passed away from a sudden heart attack. And why? When I found the information she had jotted down in her health diary, she was told by her doctor that, she was just depressed. She was kind of a little bit anxious. And she may have some GI issues. And if you look at that list, it's the classic presentation of how heart disease presents in women. So, to bust the myth, 60 million women have cardiovascular disease in the US. It is the #1 killer of women. We talk a lot about breast cancer, which is incredibly important. Cardiovascular disease kills a lot more women. And if you were to think about the impact, if we were to close the women's heart health gap, $28 billion of opportunity here in the US. Some other stats that I think are helpful, which we already heard about, 50% of women are more likely to be misdiagnosed than men, just like we were talking about. Women are 20% more likely to die of a heart attack within 5 years than men. And if you look at from a demographic perspective, Black women, 59% of Black women over the age of 20 have cardiovascular disease, which is dramatically more than any other group. This is absolutely our disease, and we need to learn how to manage it. The second one is women's heart health. It's just a seniors problem. It's old ladies, right? Once they hit menopause, maybe they have some cardiovasculars. You kind of got the image, right, of the woman with old hair, or frankly, the man with old hair. But actually, that's not. We're going to walk through a little bit. But actually, cardiovascular disease starts in utero, and we'll talk about that. But we'll talk about puberty. I'm guessing many of you don't realize that it actually makes a difference. Some just key facts. When you actually start your period is highly correlated to cardiovascular risk. How irregular your periods are also increases your risk for cardiovascular disease. It is not something that you think about when you turn 60. This is relevant already at adolescence. Another one, and I think thankfully there's been getting more awareness of this, is that pregnancy is a benign event in a woman's cardiovascular life. There could be nothing that's so not the case. If you actually look at pregnancy, and many of you may have seen recently in the news more information about hypertensive disorders, which is high blood pressure, we'll talk about that. 4 out of 5 maternal deaths in the US are preventable. 4 out of 5. 37% of these deaths are related to cardiovascular disease. It is the #1 driver in the US of maternal mortality. Pregnancy-related hypertensive disorders in particular, highlighted here, we'll go into the stats, which I personally suffered for, and I'm going to have stories we were exchanging earlier, dramatically increases your risk of hypertension, stroke, and later high blood pressure. You've got gestational diabetes as well, and then peripartum cardiomyopathy. Huge risks here. So I like to talk about preeclampsia. So preeclampsia is when you have the onset of high blood pressure at the end of your pregnancy, and then you have protein in your urine. 8% of women who are pregnant have preeclampsia. 8%. That is a very high number. And you can see some of the statistics, right? 4x, quadruples your risk of high blood pressure. It's very high prevalence in Black women, consistent with the other statistic that I shared. 23% of maternal deaths worldwide is from preeclampsia. The thing with preeclampsia is, if you're not familiar with it, you cannot feel blood pressure. It's a silent killer. You don't know until it's too late, unless you get appropriate care. This is something that many people aren't tested for. They're not taught about. And for someone like me going to Mass General, having great care, even though I was insisting, I know what's going on. I'm extremely privileged, and still, I wasn't listened to. I was told that I was causing my blood pressure to be extra elevated, that it wasn't really that bad. And then ended up getting stuck, blood pressure going through the roof, getting thrown back at midnight, back to L&D to pump me through the IVs to make sure I stabilized, and being stuck in the hospital for a week because they couldn't get my blood pressure under control. And I knew what was going to happen. I knew that it was a problem. I was advocating for myself. As we're talking about, best place, it's still an issue. And so many women, in particular, so many women die from preeclampsia expanding because it's fast and there's no warning signs. The next one is that menopause is just a nuisance. As Tim mentioned, we had a whole session on menopause last year, but it's really important. Menopause actually does have a big impact, and particularly with cardiovascular disease. So if you look at on the left-hand side, as a woman's age, so at the beginning your estrogen goes way up and then it comes way down during menopause. And you can see that there's a direct correlation to cardiovascular disease risk as your estrogen goes down, because it is generally seen as a cardioprotective. What I think many people don't realize is that 77% of women with frequent VMS, which is hot flashes, actually have a higher risk of developing cardiovascular conditions. So this is not just a nuisance, but actually there is a direct correlation. And so you need to be aware of that, hot flashes actually are real and do have an effect. It's not just a nuisance. And there's also the increased risk of other conditions as well. So very important to be aware. There's other conditions, of course, that impacts, your orthopedics and all of that, as well as greater risk on menopause, but wanted to share that. The next one is you're saying, well, okay, here's all of the information. Like, there's a lot of risks, there's a lot of gaps. But my providers, they know about this, right? Like, they're going to actually help me get through this, and I can trust them. Unfortunately, I don't have some good news. The one good news is, if you want to help yourself, find a female provider. The data suggests, and this is not just in cardiac care, there was actually a recent article that The Economist published on this topic. Consistently, women actually provide, women patients actually live longer and have better care if they have a female provider. The challenge is that only 15% of adult cardiologists are women, and if you want to go to interventional cardiologists, it's 4%. So it's kind of hard for every woman to have, a female provider. And just the stats are pretty staggering. So women are 2.5 times less likely to be referred to a cardiologist after chest pain presentation, particularly if they have a male physician. They're less likely than men to receive the appropriate treatments. I mean, we looked at this in the claims data, and it's stark. If you look at people who had a heart attack and everything the care that they received, every single step, they were referred at lower rates. They were, got imaging at lower rates. They got treatment at, every single step of the way, women are not getting the same treatment as men. And if you think about medical education, 70% of medical schools don't even teach sex-specific heart health. And we know that it's actually quite different. And the self-reported stats are equally terrifying. Only 22% of physicians and 42% of cardiologists actually feel well prepared to provide care on cardiology for women. Another myth, well, they're researching it, right? We're actually putting money to try to close this gap. It's actually pretty stark. We look at basic scientific research, and you just look at animals, right? So one of the things you think about clinical research, you first start on animals, then go to humans, and then ultimately get in the clinic. If you look here in the gray, over 70% of the animals, I love how you're rolling your eyes, but it's like over 70% of research is done on male subjects. Well, how do you learn if male and female biology is fundamentally different if you actually only have males in your studies? Only 16% of them have both male and female. And what's interesting is you move to clinical trials, it's not much better. And if you look at those clinical trials that do have representation, I just highlighted that postmenopausal and menopausal women are the ones that are great at risk, they're dramatically underrepresented. So you're getting younger women. You're not even focusing on the women who are actually at risk. So needless to say, we have a lot of work to do. And the same thing goes in terms of investment. Women's cardiovascular disease is a very small sliver of investment of research funds. So unfortunately, we have a big gap, and we don't have the research funding that's set up to overcome it. The good news is, if we did overcome it, as I highlighted, it would be equated to 1.6 million years of life lost for women in the US annually. 1.2 million annually. And that's 28 billion of annual economic opportunity. So absolutely amazing opportunity. There's a business case beyond the obvious. We all want to be healthy. So what do we do about it? And of course, we'll get into the details here with our experts. But the first, which is why we're here today, why I'm here today, raise awareness so that you actually understand that there is a gap and that you talk to your friends, to your family, to your daughters to make sure that they understand that there's a gap. Not only for their own care, but to advocate for their family and their friends, and also beyond. The second is we need to, improve routine health data collection, diagnostics, and treatments. Right? We don't currently, most of the algorithms don't actually take sex into account, which, as we talked about, is incredibly important. We need to have the sex-specific research. Right? It's not okay for all of the models to be predominantly men, because we won't find the solutions that we need. Today, the presentation for women, it's very different, and yet we really don't understand. And some of our diagnostic tools don't even work for women because of the different forms of cardiac disease. We need to invest more, and we need to help equip our healthcare providers. Right? They didn't get the education in medical school, so how do we inject rapid continuing medical education so people are aware of this? So without further ado, we'll jump into the panel discussion, but hopefully gives you a little bit of a primer of women's heart health gap in the US. Thank you. And now I will welcome Janae on, who will lead us in an amazing conversation.
Hello. Say it back. Y'all can do it. Hello. There we go. You all look so beautiful tonight. So I am Janae Osterheld. I am Boston Globe culture columnist and deputy managing editor and founder of A Beautiful Resistance and community partner to the Museum of Science. Thank you. When I was first asked to partner up with this panel, I wasn't sure about it because this has been, since we're all sharing personal stories, this has been a year that asks many questions and is teaching a lesson about the fragility of life. I think it's very easy for us, especially women, because we think we have 8 arms, and we try to do all the things. And sometimes if you're feeling just good enough, you think everything's okay. But I have just buried my 4th friend, under 44, in this calendar year of 2024. 3 of the 4 were women. 2 of the 4 had heart attacks. 3 of the 4 were Black. 1 died post giving birth. And I have a friend right now who is in CCU because she had a stroke while I was at my other friend's funeral. None of these people know each other. None of them are from the same state. They are all from different eras of my life. And I tell you this very sad, tragic story because you need to understand that just because you look healthy or feel good, or your doctor said there's not something wrong, but you might think there's something wrong, doesn't mean everything's okay. We have to advocate for ourselves. And conversations like this is how we raise awareness. Those stats we just saw are real. I'm living it. And I don't know what the universe and God are doing with me, but I'm going to keep showing up. My first, actually second, because we already have our first esteemed panelist. My second esteemed panelist is Nandita S. Scott, who received her MD from the University of Ottawa in Canada. She completed internal medicine and cardiology residencies at the Ottawa Hospitals and Heart Institute, where she was also chief internal medicine and chief cardiology resident. Y'all know that means she run things, right? She is knower of things. She then completed an echocardiography and clinical research fellowship at Mass General. In 2007, she facilitated the MGH Corrigan's Women's Heart Health Program, which has become a robust clinical. Basically, some of those issues we saw up there, she's working to solve them. She's also director of cardiovascular medicine at MGH. She's received several awards, highly accoladed. In 2023, she was named the first director of Mass General Brigham Women's Heart Health Program with the goal of integrating education, clinical access, and research across Mass General Brigham system. Please welcome a change maker and heart saver. Now we're gonna bring up my needlepoint friend. She does the needlepoint, I do the woobles, fidget toys for adults. Sarah Picard is a pediatric cardiologist and senior expert in real-world evidence and clinical epidemiology at McKinsey & Company. All the things we just learned, she does for the little people in our lives. She leverages deep clinical and analytic expertise to help biopharma and healthcare clients accelerate innovation and address patients' unmet needs. She also practices at the Benderson Family Heart Center at Boston Children's Hospital and Harvard Medical School. Sarah received her MD from Stanford and her MPH in quantitative methods from Harvard School of Public Health. She completed her pediatrics residency, pediatric cardiology fellowship, and advanced cardiac imaging fellowship at Boston Children's Hospital and Harvard Medical School. Prior to joining McKinsey, Sarah was an assistant professor at Harvard Medical School and cardiologist at Boston Children's. Please welcome someone who's literally saving the future. Don't forget to ask questions via Slido. Hit the QR code. I'll get to you. Give me a second. I'm not used to working with the iPad closed and things. I normally have a mic that's like attached to my face. They've spoiled me here. Yes. Oh, you don't even have to do that, but that's so smart. This is why you all, are changing the world. Can we start with, because we are going to deal with some heavy topics, and we've all a few of us already have shared personal anecdotes of these heavy topics, I'd like to ground us in joy and remember why we fight. So if each of you could just say why your work or how your work brings you joy, that would be awesome.
I mean, to be not brief, I would work for free because my job is like the best in the world, and to be able to reach women, reach their families, and make a difference in individuals' lives is like so rewarding. And that's it for me.
So I think I started this thinking about the amazing moments where you save the lives and the kid goes to kindergarten. It's these dramatic sort of made-for-TV moments. But I think the piece that really brings me joy is in the sort of micro interactions where you can connect with another human being. Just to make it real tangible, today I had a long conversation with a mom explaining that their child had a new diagnosis, and she just said, thanks for calling. And that's the joy for me. It's the human interaction.
For me, it's trying to create change, right? I'm not the cardiologist, I'm not, the physician, but for me, I like seeing the light bulbs go on. A few weeks ago, I sat next to someone on a plane, and I'm kind of a walking advertisement for women's health. And, I just started talking. And by the end, he was just like, I cannot believe, and he turned out to be a public speaker. And he's like, I'm going to bring this to all of my talks. And he's like, I was a caveman, and now you've let me see the light. And just like seeing the light bulb go off and starting to spread the word, that really motivates me.
You guys give me joy. This gives me joy, being able to add value to something that's been so heavy and hard. I was reading a stat from one of the McKinsey reports that said closing the cardiovascular disease gap between men and women could help women regain 1.6 million years of life lost because of poor health and early death, and boost the economy by $28 billion annually by 2040. Can someone break this down for us?
I'm happy to start, and Megan, you can chime in here. But I think when we think about economic opportunity, it feels really abstract. Like, how does a life have an economic value to it? And I think what we're talking about here is not that an individual life has some dollar amount. I mean, even just life is an infinite value. It's really about understanding at an economic level what women contribute. Because at the end of the day, women are sort of the epicenter of our economic engine. We are the caretakers, we are workers, we are caring for our children, we are caring for our parents. And when a woman is not in good health, they can't contribute to the workforce, they can't take care of the children, they can't take care of their parents, and that has an incredible economic impact. And one of the things that's really important is that about 60% of this gap is occurring during women's productive workforce years. So if you have an MI, a heart attack, if you have a complication of pregnancy, you may not be able to go back into the workforce. You can't go back at full productivity, and that has an economic impact. If an employer loses you from the workforce, that has significant economic impact. And so when you take that and you bring it all back together and you sum it all up, it ends up being this massive economic opportunity. And when we talk about years of life, the 1.6 billion years, it's a measure of understanding not just years of life lost due to premature death, but also years of life lost due to poor quality of life, not living at your absolute best. Megan, I don't know if you would expand upon that or.
I think you got it.
What can we do to raise awareness around CVD? This is the number one leading cause, but to your point, and it is incredibly important that we do support breast cancer and the many other things that are killing us, but this is the number one leading cause of death, and I don't feel like it has the branding or buy-in that some of the other things that we march for and race for do. Why is that, and how can we flip this to raise awareness?
Yeah, so I've been doing this a long time, and it's really disconcerting to see that we still have so much more to go. The Go Red campaign through the American Heart Association has done a lot to raise awareness, but I just don't think we're reaching the people that need to be reached. So I think we need to really reach women of color, different socioeconomic groups. These individuals may not know about these risks. Their physicians may not know about their risks, and I think we just need to do better at reaching the people that really need us. We're not doing that well enough.
Yeah, and I'd say also just young people. Like actually, the latest data when we were talking to American Heart Association, right? The data is actually like awareness is going down. It's not that we've even just plateaued. Like we did have, I would say, I don't say a heyday, but like that's actually how I found about because when my grandmother did it, I like researched and it was like starting to become a thing. Like everyone was sharing on social media, right? About watch out. These are the symptoms of when a woman's having a heart attack versus a man. But that's just disappeared. And so I think I think also people don't understand, like preeclampsia, maternal mortality, right? This is big and it's now, right? This is young people. And I think people just think about a heart attack as an old person, and we have to re-educate everyone and make sure everyone understands this.
Did you want to add
I
something?
just want to add something. So in terms of the maternal health crisis we have in the United States, it's really terrible when you think about the lack of education that healthcare providers are getting about this, especially cardiology trainees. So, we're very blessed in Mass General Hospital where we pound our fellows and our trainees about, women die of heart disease, and this is and make sure that they all know and understand what happens to a woman when she's pregnant. But it's not as lucky across the country. So we're trying to. Our team are building these modules, educational modules, to provide free to all cardiology trainees across the country so they can get some basic understanding.
And with maternal health crisis, just because Crystal just died months ago, something that, no matter what, we all would have been bothered because she's our friend and she was an athlete and incredibly healthy. She was going to the doctor regularly. She had all of the resources. And a lot of times when people tell these stories, they tell them in a way that makes you forget that Serena Williams and Beyonce went through these things. And that there's, yes, racism and classism play a role in all of these things, but there's also a very real thing happening with pregnant women and just some sort of malfunction, dysfunction in medical care in this country specifically. Beyond just boilerplating it to racism and classism, why is this happening?
Yeah, so sorry to hear about your friend. It's obviously heartbreaking. I don't know if the audience knows that maternal mortality in the United States is worse than any developed country in the world. Black women in America have similar maternal mortality than women in Syria. This is unacceptable in a country of our wealth and education and expertise. Why is it happening? Yes, definitely the racism. There's maternal care desert, so Black women, Native American women are more likely to live in a maternal care desert, so they don't even have access to basic maternal care. With the post-Dobbs decision, a lot of healthcare providers are leaving states that don't have access to terminations because it's just really hard for them to work. So this is actually just going to get worse. And because of the Dobbs decision, we're expecting maternal mortality is actually going to worsen.
What are the questions that we can be asking? Just because of the year I've been thinking, like, what am I not asking my doctor? Like, what tests should I be asking for? Are there screenings that I need? My friend Corey, the funeral I was at this weekend, and he's a man, so he's not the topic of our discussion. But Corey's mother was a Black woman, and she died the same exact way around the same age. A heart attack, a very specific type of heart attack, all at once. She was a psychologist. They come from all of the things that you think will shield you that don't. How can we combat this? Like, what do we need to say? What are the things, even if you have a Black doctor or a doctor who looks like you or a woman doctor, how can we go to the doctor better prepared to help protect ourselves and fight for our health?
I mean, I think it starts in really early childhood, and I can speak to that initially. I think the first thing that folks as parents need to be aware of is that their own child's cardiovascular health, as Megan alluded to, begins in utero. When moms have hypertensive disease, that fetus has a higher risk of cardiovascular disease. They have a higher risk of hypertension. They have a higher risk of stroke. They have a higher risk of heart later in life. I think the vast majority of parents have never been told that. The other piece that's really helpful is that parents understand what their child should be receiving with regards to cardiovascular care during regular childhood, and I think most parents haven't gotten that message. So for example, people are surprised that their child is supposed to have their blood pressure measured every single year starting at age 3. Why is it age 3? Because have you ever tried to take a blood pressure on a 2-year-old? Like, it's wrestling a monkey. But most people don't realize that every single year their pediatrician should be checking their child's blood pressure and sending them to me if they're elevated. Every child between 9 and 11 should have their first lipids checked, or maybe even earlier if there's a strong family history. And I would be shocked by the number of people, when you really take that family history, when you really dive in and you ask about, the grandma and the aunt, you really go through it, they have a really remarkable family history. And then they should have it again, when they're 17 to 21. And they don't know that we should be asking about those irregular periods, or that it's a risk factor for cardiovascular disease. And that's not even to talk about the fact that girls in adolescence start to collect increasing risk factors because they drop out of sports. I hope folks saw the campaign that was done during the Olympics about keeping women in sports. So that's just to say some of this conversation about what should you ask actually begins with your 3-year-old, which I think that part of the conversation needs to enter the dialogue, because I think we start to think that cardiovascular conversations, maybe they start at pregnancy, but even as we've alluded to, a lot of people aren't having them till even menopause. So I'll stop with the youth side, because you take over once they're 18 and above.
Yeah, I think it's awareness that, in training we're taught about high blood pressure, high cholesterol, smoking. Those are the risk factors I need to worry about, but there's this huge array of sex-specific risk factors that are completely been ignored. I didn't learn about them at all when I was in training. So premature menopause, having menopause before the age of 40 is a cardiovascular risk factor. Preeclampsia, gestational diabetes, placental abruption, where your placenta tears off your uterus, preterm birth, and small for gestational age, small babies. Those are all risk factors for cardiovascular disease. So it's, and our regular risk factor calculators, when we estimate everyone's individual risk, does not include any of these risk factors in the equation. So we were talking before, if you had a history of preeclampsia, a lot of people don't know that you should probably start cholesterol medication sooner than someone who did not have preeclampsia. So I think, and you asked before about how do we I think patients need to advocate for themselves, and if you don't feel like you're being listened to, then find another provider, and just be present for yourself and advocate for the needs that you have.
I was just going to add, I also think it sounds like a trite terminology, but there is a sisterhood component of this. And we talked about breast cancer a little bit. And I think one of the things that has really been great is women talk about with their friends. They talk about their mammograms. They talk, oh, I had this lump. Like, where did you go? And they talk about, hey, dense breasts, and maybe you need an MRI. I mean, and, Glennon Doyle and Abby Wambach did, brought experts on, and they're talking about this. And that's awesome. But we need to start talking to each other about our cardiovascular health. We need to be like, hey, I had my lipids checked, and I don't know, is this right? Is this not right? And that's not part of that sisterhood dialogue in the way that breast health has fortunately become. So I think one of the things that we as individuals, every person here can do is be willing to have the conversation with their friends and their sisters and their aunts.
And to hold those sister friends accountable, because, sometimes we have friends who say they're going to go do a thing for their health, or they're going to join the gym, or they're going to go to the doctor and get that pain in their back checked out, or do physical therapy, but they're too busy because we have 8 arms, and we're women trying to do all the things. How can we exercise the power we do have, not just to advocate for ourselves, but financial power, our civic power? What can we do to better support this research and the funding and the things that need to happen to build these pipelines?
I mean, it's a good question. It depends where you are, right, in the stakeholders. On the healthcare side, which I know is a segment, it's asking the question, and this is regardless of whether it's cardiovascular, right? Is there a sex difference? Why are we go to the mice, why are we only using men? Do you even know that if they're male or female, right? I think across kind of the whole entire thing. Asking the question, right, of your providers, right? Asking the question, well, is that relevant for men and women, or is there a difference? But I'll be honest, I don't think there's a really good answer in terms of how you mobilize. I do think, with the American Heart Association, I think we need to do Go Red, on super steroids. And we need to focus on, the younger generation, because I just think by the time we get late, we absolutely need to address that, but we've sort of lost a lot of it because unfortunately it compounds over time. But yeah, I don't know.
And you mentioned education before, so the healthcare fields really have not been paying attention to this. And even in cardiology, the cardiobstetric sessions, so women with pregnancy, are usually in the top room in the corner, tucked away so nobody can get there. And we made a push that the cardiobstetric sessions need to be on the main walkway so anybody can walk in. It needs to be on the main stage. It's just really, we have to educate the next generation of healthcare providers to think about these things. I was recently speaking to the chief of cardiology, and I said we should mandate in a nice way that anytime anybody at Mass General Brigham presents a talk, they need to have a slide on sex and gender specific differences, because and one, it'll make the speaker think about it, but two, Mass General Brigham has many people speaking all over the world about many topics. We can really spread the word that way. So I'm working on that.
Yes.
I love that.
Speaking of the slides, the slides we saw earlier, are those going to be shared?
We won't share the slides, but all of this data all comes from our report, so we'll send that out in the email. But there's so we have the Women's Heart Health report. If you type in McKinsey and American Heart Association Women's Heart Health, but we'll send it around. But all of this is in there. I highly suggest reading that. Also, more broadly, if you're looking for kind of a primer on women's heart health, my favorite book is Sex Matters: How Male-Centric Medicine Harms Women and What to Do About It. And it goes specialty by specialty. So it has a piece on cardiovascular disease. It has every kind of specialty. And at the end, it actually has a cheat sheet list of things to be asking your physician, which I think is quite helpful.
That is helpful. I know you said it's a complicated answer around mobilization, but surely there's something we can do to shift the paradigm of how they're using only male test subjects, and just the very obvious sexism at play and ageism at play in these studies. What can we do, those of us that are outside of the field? There's got to be something.
I think one piece is with the Boston Club here is a great partner in this, really elevating women in all areas of leadership in all sectors. Because when women are in leadership, They think about these issues. They invest in women's heart. If you are a female-led VC firm, you're going to invest in female founders, and you're going to invest in femtech that might address. There's so few startups that are actually devoted to women's health, and even fewer devoted to women's heart health. So we just, anytime in any organization you are, when you promote women up into these positions of decision making, I think that has impact. I'll give a 2-second anecdote of something that came across recently that just blew my mind, that really brings us home. It was a large pharmaco, and a drug failed in its phase 3. So that means it wasn't going to get to the clinic. And
lots of money.
And a lot of money spent on this potentially promising drug. And the question they had was, well, why did it fail? Was it a dosing problem? Does the drug not work? These other questions. Well, I pulled up the phase 1, which is where they try to figure out how to dose the drug and how does the body metabolize it. And guess what they forgot to include? Women. Guess what they also forgot to include? Non-white men. So they had an entire phase 1 of just white men. And then lo and behold, when they went and they had women and they had a diverse group of folks in phase 3, it failed. Now, I don't know that was 100% the reason, but this is in 2024, and they spent a whole lot of money. And I just have to believe that if we had a few more women in the room and a few more folks in there, somebody would have said, there's something off about this phase 1. And that may have changed the course for them.
Anyone else want to chime in?
I just wanted to add, the workforce is so important. So cardiology, I think, has taken a step back because most cardiologists are not women. When I was in training, there was no women above me or below me. I was like the only single woman. And also, it doesn't mean that women want to go into cardiology, because if they see men, it's a harder field to get through. Now, 15% of women are cardiologists. In the current cardiology training programs across the country, it's 25%. That's still not enough. But we don't only need women, we need our men to partner with us. We need them to be part of this.
That's what I was going to ask.
Yes. We need our male colleagues to be part of the solution. We actually have a male physician in our women's heart health program. He's amazing. He's doing amazing research in preeclampsia. And so that's what we need. We need our men to partner with us too.
When it comes to our men partnering with us, something I just want to hold space for is that because the patriarchy is so deep, it's in the air that we breathe, no matter what field we're in, it inevitably washes over women and them too. Like we are capable of that. And I have been ignored by women nurses and doctors before. So what can we do to sort of fight the patriarchal gaze or heal the patriarchal gaze in medicine so that we can make room for us to actually get the proper care that we need? What are some of the steps to take to sort of, outside of hiring more women? Because to my point, sometimes if you're being taught in a patriarchal, if the person teaching you is teaching you these things, then you're going to enforce those things. Just the same way we saw with doctors of color ignoring patients of color pain because they were taught to.
Yeah, I can say at Mass General, there's a huge push on, implicit bias training, make sure that everybody gets that, on a routine basis. And I think, women in leadership, women physicians, and just education on sex and gender-based differences. I think there has been a great improvement on that over the years that I've seen at my time there.
I also think there's an important push that it has to start with the individual, meaning I have to understand my own internalized biases. In order for me to just because I am a woman does not mean I don't have internalized sexism myself. And I think that what we've learned from starting to learn about understanding racism is that we really have to understand ourselves and understand where we're coming from first. And so I also take it as a directive on me, a personal task that I need to is help my own education and understanding so that I can then do better too. So I don't think that we are beyond sexism because we are women.
The other thing is, we have to learn ourselves and then advocate, right? I think the one area where we have seen success, and I would say the one bright spot in women's health, which still needs work, is breast cancer. And that's because some senior women were fed up and they went and fought, and they fought, and they fought, and they mobilized. And that's what we're going to have to do to get large-scale change, because that's what started to move the needle in actually getting research funding. So, mobilize.
Do we know what is causing the rise of CVD and stroke and other cardiovascular related issues, and not just young children, but young adults? I've been seeing more and more research that supports that just people that didn't used to be at such a high risk are very much at risk.
So, I mean, obesity and physical inactivity is certainly a big driver. There are other potential environmental components as well, but I think the rise of obesity and really some of the nutritional components, you can have obesity that has nutritional elements, and then you can also have nutritional components that in the absence of obesity. I think that's probably one of the primary drivers of terms of the rates at the sort of social levels. I will say that to make a small plug, though, around school lunches, because Massachusetts has done something that's been really remarkable, which is that since the pandemic, they've made all school lunches free for all kids, regardless of whether they can pay or not. And that's really destigmatized school-based nutrition. And I think that's going to be pivotal as we help provide optimal nutrition to kids in a destigmatized environment. My children get the school lunch now, all their friends get the school lunch now, and I think that's a real opportunity. But I think nutrition and obesity is a big piece. I don't know if you have other thoughts on the drivers.
I was just going to say, our food supply is not great, and none of my kids' friends want to hang out at our house because we had fruits and pretzels and everyone else had the Oreos and the nacho and the chips and all that. But I think, you go to a restaurant and what's on the kids' menu? It's like cheese pizza, chicken fingers. I think we just need to teach and work on the next generation just eating better. Our food supply is just not great.
I have to ask, what about, just because I've seen it in my life this year, none of them were obese. So how big a factor does stress play in these types of things?
Yes.
Because what they all were was stressed.
So we have ignored for a long time the heart-brain connection, and there's a huge impact of stress on the body. And I don't know that it's more in women, but there are sex-specific disorders such as Takotsubo cardiomyopathy or stress cardiomyopathy. There's a specific type of heart attack called coronary artery dissection, where you don't get plaque in your arteries, but your artery tears. And both of those conditions are more common in women. So there is a total truth that stress can cause heart disease and can cause you to die, have a heart attack, stroke, etc. So I never discount stress. I think we used to say it was one of the softer risk factors. Not so true anymore.
And I think we have to, I'd be curious how you deal with this, but I think we have to be careful in the conversation around stress, which is that the stress is not the woman's fault, and it's not something that you can just turn off. So if the physician says, you're stressed, it almost feels sometimes like a blame game. Like, if I just chill out, if I go get a massage, it'll all be fine. No, the stresses are because, we don't have good childcare in this country, and you're probably in the sandwich generation taking care of your parents and your children at the same time, and there's wage gap, and. So, I just think it's important to say that stressors, or living through a pandemic, are not the fault of the woman, nor is it often something that you can just switch off with, meditation. Although meditation
if you're a
has
person of
good evidence.
color or a queer person or a marginalized person, otherized in any way, that you certainly can't turn that off, and that comes
Exactly.
with an inherent level of stress in this country.
Yeah.
And sometimes I just wonder how many physicians are taking that into account.
So I would add that even in patients with already established heart disease, stress is a risk factor for them to do worse. And so in our women's heart health program, we've actually embedded a psychologist into our program. So our patients now have access to cognitive behavioral therapy to deal with the stress response. We're not taking away your stress, but how you respond to the stress. And I think that there has to be more data on using antidepressants and SSRIs and things like that in people with cardiovascular disease to improve outcomes, because depression, stress, anxiety just makes people with heart disease do worse, men and women.
And to add one last thing on the stress piece, because I think it's a really good topic, is there's data to show that actual stress, chronic stress, racism, for example, has been shown that actually changes the expression of your genes and the DNA methylation. And so it's changing, the stress is actually changing some of your biology.
You know how you broke down kind of getting your family history from a young age and at every stage. Is there an intervention for heart health at each stage of life beyond family history? Somebody had this question in the Slido, and I actually was like, oh, that's actually an interesting question. Like, is there different stages at your life where you should be asking your doctor for different things beyond declaring family history?
So in the pediatric range, yes, we will do very different screening protocols. If you have a very strong family history, we actually may even send additional blood work, a separate lab test, like we were talking earlier about lipoprotein A and some other things, if there's a strong family history. So from a testing perspective, but the questions are, well, what are you going to do about it differently? We may do something differently. We may, depending on levels and family, we may initiate drug therapy earlier. We may initiate more aggressive lifestyle interventions earlier. And really the key often is keeping them in care, because it can be very difficult as kids transition to adolescence and young adulthood. Young adults tend to fall out of care, especially when they go through an insurance gap as they transition off their parents. And so just simply knowing that they need to stay in care can be an intervention even in of itself.
Yeah, and then for the adults, there's well protocolized frequency of checking cholesterol, checking, for diabetes. Everyone should have a blood pressure every year. So, and I would encourage everybody to know what your blood pressure is, know what your cholesterol is, know what your blood sugar is, and know what normal is, so that you can question your physician when you see them. Also, a lot of women come to their doctor's office and look perfectly healthy. They're young. And these sex-specific risk factors we talked about are not even questioned. So it's knowing what those are and whether you fall into those categories.
We all talk about equity. And I've heard so many stories just in this less than hour, like how Barbara opened. I think when people talk about privilege, you would never think that she would have to endure that. She should be able to say she's feeling a thing and someone should listen in a country that has placed these type of standards on everybody. And yet, so what does equity look like in practice? Like, what does that look like? You go to the doctor and
they listen to you. No, I'm serious. I mean, they're well-educated. They listen to you, and they understand. I mean, this is one area where I get excited about AI. There's a lot of concerns about AI because they're using data that, for example, doesn't use, women or other, diverse groups in it. But I think the other challenge, right, as a cardiologist, there's new research coming out, every day, or frankly, just, your general practitioner. How are they supposed to know all of this, right? And so as we can use more tools, for example, so it's listening to the conversation as it's transcribing. Can it say, oh, that's an interesting thing. Ask a few more questions. This looks like it could be, heart disease, or, say more about their family history. There might be something there to help, be a co-pilot and actually try to do that, because I think that's also the thing we need to do. But I mean, listen, get the support and then intervene, right? And I think transparency is, as we look about, like I was looking at the claims data, right? If you can show, physicians, a whole entire, general practice and cardiologists, and just show the rates, your practice, like you as an individual, are actually referring at different rates for the same presentation, I think that makes people wake up, right? But you've got to show that data to them so they can change. And I think right now there's just not that much transparency around that.
And we just need to not treat women like little men, right? Yes. We aren't. And it's unbelievable if you think about it that, menses, menopause, pregnancy, the effect of the hormones on the blood vessels, we've ignored that for decades in cardiology. And it's just now getting the time of the air that it needs to understand how those hormones affect our blood vessels.
Well, we've ignored menses and menopause, period. I didn't even mean that as a pun, but it works. There is actually a lot of questions about menopause and CBD here. Like, we could have a whole hour. So I think to face that head on, maybe just talk a little bit about the intersection of menopause and CBD. Why is that relationship there, and what can people do to help advocate for themselves as they go through these changes?
Thank you for that. Yes, you're right. We could spend an hour talking about menopause and cardiovascular disease.
And we probably should at some point.
Yeah. Women are generally felt to be protected from plaque-mediated heart disease until menopause, at which point they start catching up to men. I think that a lot of the menopausal symptoms can mimic the symptoms of heart disease, like palpitations, hot flashes, shortness of breath. All those things can mimic it. So always, to talk to your doctor and don't, if they say it's just menopause, maybe ask for a little bit more testing, advocate for yourself a little bit more. There's a huge discussion that we could have about hormone replacement therapy, right? So it used to be given a lot decades ago, and then some studies came out that it could be harmful for the heart or increased risk of breast cancer. I don't know that that whole story is out there. There may actually be some benefits to hormone replacement therapy in certain doses and certain applications like transdermal for a short period of time after you in the early phases of menopause. So I don't think that the door is closed on even that. And I think menopause is a time when cardiometabolic health worsens because women gain weight, their blood pressure goes up, their cholesterol becomes worse. So it's a time where you need to be even more on top of those risk factors and address them and target them to better values. So again, that's just like a 2-minute blurb on menopause, but we could have a whole hour discussion.
I think it has to be a part of the series or a series. I think we're going to open it up for questions, but before we do, I like to end my moderating of every conversation before I start handing over the mic with what makes your life a beautiful resistance. And when I say beautiful resistance, it's about finding the joy and the love and the value in your beauty, in your joy, in the life you live, because we woke up today and we're possible. People think of resistance as fighting and fist in the air, and that's it. We need it. We need that. But it's also resisting the narratives and injustices placed upon us by living our best life and fighting for the lives we have, and that includes our health care. So I'm going to frame it this way. What makes your heart a beautiful resistance?
So my heart is bionic. I'll share that. I have a defibrillator and a pacemaker. And so I think that keeps me ticking. And I think that is a very beautiful resistance. And I'm very proud of it.
Ooh, I love that.
I mean, for me, I just want the world to be different for my daughter.
That's important.
I have 2 sons, so how do I answer that question? I just think there's so much work to be done in the space, and I'm just so grateful to be part of it. And if I can leave at the end of my career and know that I made, some woman who couldn't have children have a baby because she had heart disease, or prevent, a death in a patient, or have a better life, more productive life, then that'll be a career well spent.
Well, from my heart to yours, especially yours, and my bestie Tim, and you over there from the AHA, because I was Go Redding in my 20s. You are all a beautiful resistance. Your hearts and how you love is a beautiful resistance. I'm going to open it up to questions. Do I do slide up or do I run down? Okay. Are there questions that we should ask to see how enlightened our PCP is? This is actually a great question, because my friend just told me she thought she had a good doctor until she got a new doctor because the old doctor left, and the new doctor had given her all these tests that no one had given her before, and she realized the old doctor was bad.
That's such a great question. Amazing
amazing.
question, whoever asked that. I guess you could always ask, be blunt, what is the number one thing that's going to kill me? And if they say breast cancer, that's awesome, but that's not the right answer.
I like that a lot.
Anything else?
That's a good one. I think that's one of the challenges, right? Is I always had this idea of a startup to actually help people better find in a fact-based way. I think it's a really hard one. I mean, I think, as a woman, I think there is like asking the question about, especially for your OB-GYN, like the sex-based differences. And if they look at you in disgust or in confusion, that's a really good sign that they're not up to speed to start. But because you'd be surprised, right? But yeah, it's a tough one. I mean, I think the shortcut, right, which we showed on the data, everyone can't do it, but get a female provider. That actually does quite a lot to put you on the right path.
Why is the economic impact of healthy women not translating to the economic incentives of pharma and insurance and hospital protocols?
I missed the last part.
It's why are the economic opportunity of closing the gap, why is that not tied to the financial incentives for pharma or for payers?
Yeah, I mean, it's an incentive game. I don't want to go down too much of a rabbit hole, but so the GDP opportunity we're talking about, right, is a economic opportunity from a like global, I would say global participation perspective, right? So it's driving in terms of increasing the length of someone working, increasing the productivity, and also for women in particular, it's reducing their role as an unpaid caregiver because you're reducing the burden from being unhealthy. The challenges with insurance in the U.S., right, private insurance, is that they're paid by, for example, an employer, and then you have to reimburse, but they don't keep people for very long, right? And so the challenge is the way they're incentivized is prevention is actually not usually very actually ROI positive. A lot of employers that have really long employees, actually the economics start to work out because many large employers actually pay for their own insurance. But even then, a lot of that is about talent attraction and less about the return on investment. Because a lot of these things present when you go into Medicare, and then that's the federal program, right? And so for cardiovascular disease, even though we know that it's relevant earlier, the disproportionate impact is when you're older, when you are no longer on their bills.
For our last question, with so much innovation happening in Boston in tech, AI, and biotech, are there any new technologies, opportunities, research, hopes that you are excited about or dream you had available for your female patients?
Yes. So I and a team of friends and now colleagues in Missouri, at St. Luke's Hospital, Missouri, have been working for, feels like 100 years on a study for pregnant women to study the U.S. experience of women who are pregnant with heart disease and figure out what are the mechanisms to improve their care? What are we doing wrong? What can we do to improve? We've taken forever to try to get this funded, and we finally found out we got NIH funding. So the NIH gave us $8 million, and we're going to recruit 1,000 women across the entire United States and figure this out.
Congratulations.
So I'm so excited about that.
I get really excited about large data sets, and which sounds a little silly, but we have an amazing resource of insurance claims data in our country that enables us to really understand what's actually happening to patients and patients' care, and leveraging to some degree AI and bringing this data together allows us to actually quantify those gaps. And I think that's pivotal to being able to actually move the needle. Because if we don't know that these gaps exist, if we don't understand that in this region of the country, women are not getting, appropriate screening, we won't be able to move the needle. So I get really excited about big data sets and analytic opportunities that enable us to identify where the opportunities are and close them.
I already mentioned I like the AI. For me, it's like the care delivery side because we can't educate everyone enough and keep it all in their brains. And so I like the idea of let's make sure that all that information is there. We get more of it. And as you get your insights, it's beamed into everybody else, right? As soon as the findings are released.
Can I add one more thing?
Yep.
So, I'm an expert in cardio-obstetrics, but there's very few of me across the country. The majority of women who present with pregnancy and heart disease are not going to have access to brains like mine because there's just not enough of us around there. So we, like I said, educate the next generation of trainees. But the electronic medical record, whether we like it or not, is actually a huge tool to use this. So Dr. Hamid is an amazing woman in California, and she's developed this tool that pops up in Epic. So if you're pregnant and you have these risk factors, it says call cardiology. And it's things like this that are going to change things for the better.